Okay, the struggle is real because I have one presentation and then I have 2 pages of notes I've made from everybody else speaking. So I'm torn between abandoning my presentation and just reading out all of these, but I can't read my own handwriting, so that's not going to happen. So thank you very much to the HRB and to Teresa, I think, who's to blame for me actually being here today. It's really lovely to be in this forum, and going back to what Molly said earlier in relation to people being trained within their own disciplines, the one thing about data is that it is truly democratic and cross-discipline, to the point that I've been asked if I'm a nurse because I worked in the School of Nursing, and I've been asked if I was a dietitian because I worked in the Centre for Public Health, and I've been asked, do you not work for the university now that I work for the department? So you get to move about and meet lots of new people, and I'm very glad to be here to speak to all of you. Some of the terms that I will use in this presentation are very basic, which is deliberate. Some of them will be terminology that is interchangeable. So if you think what I'm saying doesn't tone with what you use in the meaning of a word, ask me later. So for example, Grania just spoke and used the term administrative data when she was talking about health records. In my world, administrative data and health data are 2 completely different things. So we talk about health data within health and social care, which is a wider remit to include social care data and health data. But administrative data to us is non-health data that's used by government. So for example, the census would be a non-health data set that is administrative. So I'm going to give you a wee bit of a background into trusted research environments and a little bit about the Northern Ireland Data Institute. Some examples around what we do with our HSE data in the trusted research environment, which links into what Austin referred to there and the data he would like to be able to see at a population level, and a little bit about our model of engagement with the publics. So DHCNI is Digital Health and Care in Northern Ireland. It cuts across the HSE and works with our partners in the Public Health Agency to support the work of our infrastructure leads such as BSO, who provide the IT infrastructure which our HSE is provided upon, and the trusts which deliver core services to the public. The purpose of DHCNI in particular is to put forward the vision for digital health in Northern Ireland, and recently is responsible for developing our digital care record, an individual level digital care record across the north, and also a regional lab system. But what I'm here to talk about today, and what you'll hear me mention, is our data and digital strategies, the formation of our new data institute, and within that, the Northern Ireland Trusted Research Environment. So a wee bit of background into the legislation. You can't have a meeting without mentioning GDPR, so Sarah and I have both done that, so we can tick that box. This meeting is complete. In Northern Ireland, we have the Data Protection Act, which is our outworking within UK legislation of GDPR. We also have the common law duty of confidentiality. This is not written law, it's case law, and it's what we base some of our decisions around the use of data in a de-identified or an identifiable way, in many cases based on previous uses and what we think the law will allow us to do within that remit. We have the Human Rights Act, which provides the right to privacy. Our data is our private information. The data that we use identifies ourselves and our households and our communities, and therefore we have a right to privacy in the use of that data, and any misuse of that is a breach. We also have, in Northern Ireland, our secondary use legislation, which was passed in 2016. And the reason why that's asterisked is that although we have the legislation, we currently do not have the regulation or our version of a privacy committee, which would enable the rights within that legislation, and I'll speak a wee bit about that later on. Within the outworkings of the new legislation, we currently have a Department of Health Code of Practice on protecting confidentiality. It's a reference document, but when we put in place the regulations, this will become a regulatory document, which will be issued by the department and will be something of relevance to everybody who engages with the HSE and the use of data in their provision of services and work. Underpinning this through HSE R&D, we also have innovation around the area of governance and ethics and how we will approach that in the north in a more centralised way. In Northern Ireland, our trusts all are legal entities, and currently whenever you make an application for governance or ethical approval, you do so through each of those individual trusts. We're now working on a best case model to make a centralised provision of those governance implications. So when somebody approaches to do a clinical trial, for example, across all of the UK or a European study, that there's a central point of application to Northern Ireland. The hope is that this will reduce timelines and create efficiencies. It also, though, bears into what we want to do with the trusted research environment, and I think links into with your DHA approach that you're going to have here. When you have a trusted research environment, which is a repository for all of the data across the HSC, that might be holding information and therefore may be treated as a separate site, or one site which holds all of the regional information. So when people are applying for governance, they might be applying to access some patient information or to get consent from a patient, but they may also then wish to access the region's data through a centralized point for data linkage. If they do that, there will need to be a site created in order for them to gather that approval for ethics and governance to use the data for linkage and follow-up. That presents challenges for us. Whenever people undertake clinical trials, they may want to do consented linkage further down the line. So how do we consent and cost and contract for data linkage that might happen at a timeline later than when the application is made to that central point? But these are things that we will work out, and they will work in tandem with the undertakings of HDR UK, which are looking to streamline some of the governance and contracting templates that we use across the UK, and the work of the NITRE in relation to a use of the IRAS system, which is the Integrated Research Application System, and how we utilise that in Northern Ireland. And the reason why I'm here today is the hope that we can also bridge the gap across the island to make sure that we have similar points in both governance and ethics and in data ethics and data quality, so that we can make sure that the island can be contacted and used for clinical trials and for research in population studies. So, what is a trusted research environment? So you will hear some interchangeable terms like trusted research environment or secure data environment. Or data safe haven. Trusted research environment is just a safe haven or a secure data environment where the data is placed there particularly for research purposes. But they're all the same provisioning, it's just that the definition of a trusted research environment was put in place just for research purposes. Some people put data in secure data environments for other reasons, but the purpose of a trusted research environment is to put data into what's known as maybe a library. So if you were talking to somebody who has no real understanding of what a research environment is or what a secure data environment is, what I would say is that it's a library of data where people can come into that library and they can request to access some points of information, make some notes on that, and then ask us if they can take the information away. What it is different in that we are not creating systems by which HSC data leaves the HSC infrastructure. People come onto our platforms through a governance process that we have reviewed, access data, generate knowledge, and ask if they can take that knowledge away and use it to create evidence. So this difference being that the data never ever leaves the governance or the confines of the HSC. In Northern Ireland, we have the Honest Broker Service. The Honest Broker Service was set up in 2014, and via the Honest Broker Service, you can ask for retrospective de-identified data. So typically, you will make an application to the Honest Broker Service within a defined time point for an agreed set of variables for an advertised range of data sets. And what used to happen is that you would go into a little glass box in the middle of Belfast and write on yellow paper and look at a computer that is not connected to anything else in the world and do some analysis and then go away. That was the concept of the Honest Broker Service initially, because that's where we were in our understanding of how we would keep data safe. Moving on, in recent years now, we have made some investments, and I'll speak to those in a later slide, and what we're doing under the initiative of the Northern Ireland Trusted Research Environment to increase our provisioning, both in our data quality and our data access. So under trusted research environments, we talk about things called the 5 safes. The 5 safes are a very easily defined and consumable way of explaining to our publics what a trusted research environment model gives them. So it's the 5 safes. It's safe people. Safe people means safe researchers. Researchers who want to access trusted research environments in the north of Ireland and also in the UK have to undergo researcher training. It's DEA accreditation training. It has changed slightly over the years. It gets tweaked and at the start it was a half-day course, and then it became a 3-hour course, and it was in physical setting, and now it's a 1-hour online course. It's going to be changed again because at the minute it pertains only to administrative data. It was created by the Office for National Statistics in England, and they're now going to change that to make it a DEA accredited researcher training for use of health and care data. What is a safe project? A safe project is, as you will all understand it, Have you gone through the governance process to get your research project approved? Have you filled in an ethics application? Has it had sponsorship review? Has it had ethical review? And is all of that document in place and according to the definition of approvals as set out by the trusted research environment? So in some cases, you may have to go to the IRAS system for ethical approval, and in other applications, a university level ethical approval will be considered. But what is needed is a determination at what level of governance is needed to access this data and to make that publicly available to researchers so that they can understand the governance process for accessing the data and understand the timelines for that. That's why the work that's happening, championed by HSE R&D, is of such importance, because researchers have different expectations of the level of governance that access to data requires and the timelines that governance will take place. And sometimes there are charges for governance, depending on where you apply to. Some places charge you to actually go through the governance process within their institutions. That needs to be standardized so that we can compete and that we can make sure that our populations are included in wider study inclusions. So what is a safe setting? Each of the trusted research environments has to have an accreditation for the setting and the systems that the research environment is placed on. That is ISO accreditation or, again, DEA accreditation. This can be complicated for trusted research environments because they're typically housed within platforms and systems that are within wider ecosystems. So, for example, the trusted research environment here is embedded within the business service organisation, embedded within the HSE. So when there is a specification set out around best practice for trusted research environments that might come from the EU, it might come from the UK, then we need to respond to that to ensure that we are set up in accordance with best practice. But that might mean that we are causing or we are at the forefront of an expectation or change for the provision of an IT service whenever we're embedded within different services, and it has implications for that. So one of the challenges we're facing at the minute is if we need ISO certification, can the trusted research environment itself obtain that if the wider system that the trusted research environment is housed in within the business service organisation has not yet received that accreditation? So you can end up being at the forefront while the rest of the system needs to play catch-up, and these things take time and investment. So there are particular challenges around those provisions. What is safe data? Safe data is making sure that we have a hierarchy of need in the provision of data, so researchers only get access to the data that they need to answer the specific question they've put down in their research proposal. We also have a hierarchy that we go through in terms of confidentiality. Can this research be done using aggregate level data? Can this research be done using de-identified data, in which case they come via the TRE? And in very exceptional circumstances, do they have to have identifiable data in order to answer the research question? In that regard, they'll have to go forward to our privacy committee, which is being set up under the legislation. And lastly, safe outputs. So that's disclosure control. When you've done an analysis and you've created some findings, there needs to be a mechanism by which that can go through disclosure control to make sure that whenever you have small population groups under 10, that by cross-tabbing the individuals within those groups, nobody can be identified. That is one of the key remits around disclosure control. So those are the 5 safes that a trusted research environment provides, and it provides them in an independent way. It is separate to the researcher who is conducting the research. It is separate to the data provider who put the data there. And it is done under a range of governance processes and access processes that are transparent and that are questioned and repeatedly improved for best practice. So in DHCNI and in the HSE, we are trying to move forward in that data and digital is in everything that we do. The digital strategy was published last year and sets out our vision for Northern Ireland for the next 5 years. And within that, we have a data institute. So we are currently in the discovery phase of setting up the HSE Data Institute. But we do know that the Data Institute will be responsible for the outworkings of the Northern Ireland Trusted Research Environment, which is where we try and build out from the provisioning of the Honest Broker Service. So you've heard Austin and Grania say that their aspiration is to have live, real-time data in as much as possible. That's something that we would like to achieve in terms of our provisioning through our trusted research environment. At the minute you get retrospective, de-identified data, we would like to move to a mechanism whereby we can have real-time data for analysis under the 5 safes of the trusted research environment. So These are some demonstrators that DHCNI was part of during COVID response. And the one in particular that is important to what I'm talking about here with trusted research environments is the vaccine management platform. So during our COVID response, we developed, I had nothing to do with it, I'm saying we very loosely there. We developed the Northern Ireland Health Analytics Platform. The Health Analytics Platform allowed all of the data that we wanted to use for our COVID response to be made available to both data analysts and to service providers and people providing the response to COVID. And you can see the outworkings of that in terms of there being a public COVID dashboard, a registry of people who needed to shield, a testing registry, and our Stop COVID site, and the issuing of COVID certifications. That all came from the Northern Ireland Health Analytics Platform on which the vaccine management system was set up. So what we're hoping is that with future investment, the trusted research environment capability that we currently have, which is de-identified retrospective data, will move bit by bit into a situation where we can provide access to real-time or as close to live data in a safe capacity for research purposes. But given all the caveats that I've explained around governance and the cost of these systems and the implication of the 5 safes, particularly around safe settings, it's not a mean feat. It takes a long time and considerable investment. And one of the things that's interesting about talking to this space and when we present this forum is that there is a challenge around investment monies for research. People want to pay for research projects because they can see what the identifiable outcomes are supposed to be for those. But the costing for the infrastructure around data and connectivity, the investment required for specialist services and TREs is very, very expensive. It is a very thirsty process. And then whenever we start to engage the public, it becomes risky and expensive. So this is a risky and expensive space, but it is well worth the investment. Okay, so the Northern Ireland Trusted Research Environment. During COVID response, we were very fortunate that through the national core studies, the UK National Core Studies for Research, there was a data and connectivity national core study, and Northern Ireland received significant investment in that space. Through those 18 months, HSE R&D invested that money into the trusted research environment to allow us to create an initiative to identify what we could currently do, what we are being asked to do during COVID response and in response to national core studies, and what the implications are for how we can change our service provision in this space to be able to reach those objectives. Basically what it meant was that we had what were called sovereign data sets. So they were a list of priority data sets across the 4 nations that were requested by researchers, data analysts, and policy providers for us to undertake research for COVID. Northern Ireland was in a position where we had to look at those lists and say, no, I'm sorry, either we don't have that data, we do have that data, but we don't have it in our trusted research environment, or we do not have the legislative provisioning to allow us to share it for that purpose. The Northern Ireland Trusted Research Environment moving forward under the investment through the Data Institute, we hope to address all of those challenges. So it's a big undertaking. So we're going to promote and expand the utility of HSE data through innovation and investment. So that's investment in the analytics platform, investment in remote access to the trusted research environment. So prior to 2021, if you wanted to undertake research in Northern Ireland through our trusted research environment, you'd have to travel to Belfast and you'd have to sit in a little glass box and write on yellow paper and have somebody check your outputs and then go away and come back and go away and come back to do your research. In 2021, we used some of the investment we got through data and connectivity to take part in the secure e-research platform that's provided by Swansea University. And I don't know if any of you in the room are familiar with SAIL, the SAIL data bank. If you want to look to what you aspire to be, that's what I suggest you do. Actually, I would suggest that all of you, everybody here, should have an understanding or an expectation of what you want provided for you. So don't just take a snapshot of my slides and go, I'm going to ask them if we can have that. Have a look at SAIL Data Bank. Have a look at Public Health Scotland. Please do look at what they do in Estonia and in Finland and try and understand those practices. I had the fortune of going to Estonia and literally sitting outside a bar with my friend with his phone who could open up his own digital care record and switch things on and off and check his information while we were talking, or consent or deconsent, dynamic consenting on the spot. That's the type of model I think we would all like to have. But more importantly, for research purposes, in Northern Ireland, having your health and care number that you can link to and having an expectation that was set by working within these national TREs it's easier to ask for things whenever you can say, if they have it, why can't we have it? So in Northern Ireland, it's a, well, if Wales can have it, I don't see why we can't have it. Or if Wales can do it, I don't see why we can't do it. Or why can't we do that? What do Wales do? So you need to have those models, because the only way to understand what you want to do is to understand the capabilities that exist in other places. So that's what we're trying to do with this innovation. We have remote access via UK SERP through SAIL, who I have to say have been fantastic partners to us in this space and have advocated strongly to Northern Ireland being supported and invested in to take this forward. HDR UK set up an innovation gateway during COVID. I've got all the links at the end of this slide so you can have a look at that. The innovation gateway, you can go on and through a selection of 18 different trusted research environments, look at what data is provided within those environments and what type of analysis tools you have. So if it's SPSS or how you can analyze the data. You can identify if the data can be accessed remotely and if there's an online application for governance or if you need to physically go to their safe setting. So you can go in and do a cohort analysis and check if there are people within your inclusion criteria enough existing within each of those TREs via their population cohorts to substantiate you making an application in the first instance. So have a look at the HDR UK portal. I think it's probably going to be superseded by a new innovation, which is the online IRAS form, the Integrated Research Application System. So in the UK, NITRE have an initiative whereby it's a pathway that you can access cohort identification at the start, go right through to an integrated research application system across diverse TREs, access your data, and then produce clinical trial reports and clinical trial management documents. So it's an all-inclusive pathway. I think it's still in its infancy, but Northern Ireland is part of the Four Nations approach to that. But again, it's a clear demonstrator of what can be done on pathways to data. The Northern Ireland Trusted Research Environment has a programme board, and I think what's slightly different in this programme board to that which existed previously in the TRE space is that it has representation of what we call our senior users. So it's the local universities who have data analysts and researchers who wish to use the data. And also what's interesting is that within this space, universities and HEIs have a great reach into funding through research projects and portfolios. What we want to do is move to a model where there's a percentage allocation of funding that goes to infrastructure for access to data across those research portfolios and to help influence how we prioritize our data sets. So when you're working towards building a TRE or a library, what we would like to do is not prioritize a project, but prioritize data sets. And then bit by bit, you move into having an extensive library of data, but by prioritizing which data are needed by the most people or are most important or most relevant, and invest in that data being moved into the trusted research environment to allow for collaborative working. The secondary use legislation was passed in 2016. And as of last year, I've been appointed to work up the regulations that will support the outworking of that, which will include a privacy panel, much like CAG in the UK. I know you already have that here in the Republic. So we need to set up a panel. That panel will consider applications to use data which is not de-identified. So as we said, we look at the hierarchy of data need. When somebody makes an application to use data, do they need to see the data in identifiable state? In some instances, there will be applications to use identifiable data, and this committee's responsibility will be to set aside the common law duty of confidentiality, to remove a person's right to confidentiality and allow that data to be used in an identifiable way. That will be a regulation body which will have significant standing and will be responsible for the code of practice to make sure that all of us in the HSE adhere to a new code of practice in relation to data. I'm going to talk a wee bit about the Northern Ireland Public Data Panel in my next slide. And yet, I have to say, during COVID, being part of the HDR Research Alliance has definitely been a strength in advocating for best practice and adoption and investment and recognition of what has happened in Northern Ireland, significant changes that we've undertaken in the last 3 years by linking in with people who can demonstrate best practice in this area, for example, Wales. This is a wee bit of it. This is a slide that shows how you can use a TRE model to access data and what that means for policy impact and policy change. So again, going back to what Austin and Grania referred to earlier. So typically people who are analysing data are looking for patterns, not people. And they're looking across regional variation, rural and urban, inpatient and outpatient, hospitals, care homes, and residential settings. Within the Northern Ireland Trusted Research Environment, we have HSE primary and secondary care. We have links to our disease registries. We have enhanced prescribing database, secondary care admission, emergency care, maternity care, death records, and linking into personal demographics, which is the household structure and residential setting. So through one application to our trusted research environment, you can access those data in a retrospective, de-identified way. It's where we are now. We would like to move on to having access to almost real-time data, but this is a significant provisioning of data currently that exists. So what does that do in enabling life course analysis? In relation to HSC data, we can look at who does or who doesn't have access to care services, who does have access to care and under which circumstances. What is it about an individual and their demographic and their household and their disease registry linkage, and what does it say about themselves? What do we know about that person, and what does that mean about the outcomes that we can determine from the data that we have? So in a lot of cases, we would use prescribing data as a proxy for people's health status or for people's outcomes or for people's health status at the minute. We'd like to move to using self-declared reported through census and linking to census, but we're not there yet. In England and Wales, you can link health records to your census records, which is somewhere that we'd like to get to in Northern Ireland. We currently have the Northern Ireland longitudinal study where you can link to 27% of the census from your health records, but we would like to move to full linkage of the census. And we can look at types and causes of end-of-life care. So it gives you that ability to look at patterns and outcomes without actually looking at the individual person. So you're looking at individual level data, but in a de-identified way and in a controlled setting. And what does that mean for policy effectiveness? TREs create a collaborative space where data can be provisioned in a safe manner. And that allows people to look at the data quality. People who are data analysts who are frequently using data from across jurisdictions can look at your data and tell you what's different about your data, what is good about your data. They can increase the reporting mechanisms against metadata so that your metadata provisioning increases. Just because you're the data owner doesn't mean that you understand the data, and just because you're the data owner doesn't mean that you know what questions need asked against that data. By creating a TRE space, you're enabling that to happen. Better use of data and more cross-dimensional, cross-sector use of data means that we can identify what is missing from our current evaluations. So if you're using one standalone data set to create evidence, when you shift that to using multiple data sets to look at multiple cross-policy questions, you get a very, very different and more complicated answer, and you can identify who is missing from your data. You get equity of policy impact on service provisioning by including the whole population. So when you're looking at your whole population in a de-identified way, your ability to generate evidence which can impact on policy is greatly increased. So what are the benefits of the TRE? They are efficient, they are collaborative, and they are cost effective. So you ask for the data once, so the painful process of does the data exist? Who is the data owner? Do we have a legal gateway to bring that data into a TRE? Do we have a data dictionary? What is the metadata quality of this data? Is all done once and is continually improved as each person comes in and works on the data. We can identify the ability of that data to be linked. In Northern Ireland, we do that in this TRE through the use of our health and care number, but it can be done through probabilistic linkages and utility of other data sets. So just because you don't have a health and care number doesn't mean that you can't link the data, but it does make it definitely easier. I'm reading through my notes from earlier to make sure that I'm covering everything. So yeah, it's an independent place. The trusted research environment is an independent collaborative space. So you're not reliant on the relationship between the researcher, the data provider, the data owner, the person who's giving you permission to use the data. You're not reliant on the one individual PPIE rep who is sitting saying, yes, I think you should use that data. It's an independent place where you can be assured of the governance status of the data, and you can have multi-professional people looking at data from different perspectives and reporting on that data quality and telling you what you're missing. Okay. The most important things about TREs is that it gives a level of confidence to the public that their privacy is being protected. The challenge around TREs, though, and the use of HSC data whenever we talk about public engagement is that in many cases, engaging the public in a conversation around their data in a general way is very different to asking somebody who's a current patient, can you use their data? So a classic example would be if you ask a person who currently has cancer, can I use your data now to do this? They're probably going to say yes. But in a very abstract way, if you said to me as a member of the general public, can I use your data that we collect for health and social care for some research? That's a very, very different question. So how do we engage with our publics as partners when we shift the conversation to being patients who are embedded within individual projects? How do we change that conversation and engage the public as our partners in a general discussion around the use of their data for their benefit? So some of the key questions are, what does it mean to have public engagement and involvement? Where should the public be engaged in that whole data life cycle? Do the public need to understand that there is ISO accreditation and what that means? Do the public need to understand what we do to link their data, or if their data is linked, if they're not identified in the linkage process? Do the public need to understand what type of governance levels there are? Yes, I would say they do. But more importantly, how do we design the utility of our data that the public understand that there is benefit to them in doing this? How do you define a public benefit that is separate to asking a patient who's engaged in a care pathway, who understands the benefit of a particular research project? How do we engage the general public in a conversation about their benefit? Through the money that we were invested through HSC R&D from the Data and Connectivity National Core Study, we developed the Northern Ireland Public Data Panel. We conducted the pilot during COVID, so it was certainly very restrictive and it was done remotely. But our ambition for NIPDP is that it is a cross-sectoral piece of infrastructure for Northern Ireland where we can engage the general public in discussions around the use of their data. So what we want to do is create a forum where we can invite a cross-section of our community to be together in a forum and be tooled up and understand the terminology and be engaged in the processes of discussion around the use of their data, whether it's data for health provisioning, data for services provisioning, administrative data, health data, non-health data, and commercial use of our data. How sensitive or not are the public to the use of their data for clinical trials, and which of those are perceived as being publicly beneficial or commercially beneficial? Who defines what is the benefit and how are we going to evidence that? And how does their decisioning within that inform how we engage the public during our governance processes and in the setting up of services which they ultimately will benefit from? So that, look, I want to look down at my notes actually because I have so many things written down here, which is my other presentation for later on. So just to say that from Isabel's first slide today around creating a toolkit, one of the things we'd like to do within NIPDP is to develop a toolkit in how do we set up a public panel, how do we make it public and not patient-driven, and what are the differences in those things, and what happens whenever you create a panel of people who are informed from the public to engage in that concept. What happens if you ask that informed panel a question about the use of their data, and then you ask another random selection of people who have not been tooled up to understand the question? What is the difference in responses to those, and what does that mean for us whenever we reach out to the public in the use of their health and care number, the de-identified use of their data, the consultation that's needed around identifiable use of data? So that's around the toolkit element. Gary and Teresa both referred to the IGNITE study and where to embed PPIE. It's a definite challenge of how do you embed the public whenever we're not perceiving them as a patient, but they're a social partner. Where do we engage with them and embed them in the processes, and where will they find the benefit to them and to us? And finally, my last point just on Jonathan's was, if we're going with the Kevin Bacon approach of the interoperability and how close you are, the 3 steps of separation from people, one of our experiences of Northern Ireland is that although it appears that good evidence creates policy change, what we have found is that if you create enough noise with your public or with the people that you've embedded in research studies, they will advocate for you and they will tell your politicians and your ministers what they want to happen to their information because they understand the benefit of it. Lots of links and references and many thanks.